It's very nice to be here. I really appreciate the invitation. I'm going to kick straight off because I've got quite a lot to go through, but I'm going to start with a quick introduction to what endoscopic ear surgery means. Many of you will have been introduced to it, but essentially what we're trying to achieve is access to the middle ear via a much more direct route, taking the ear canal instead of the postauricular through the postauricular tissues. And there has been some obstruction to that and opposition, talking about some of the challenges involved. So I want to address some of those just quickly. In terms of suction, we have now good control of bleeding using various techniques. And we also have access to suction instruments, which have made our life a lot easier. In terms of three-dimensional visualization, well, there are 3D scopes, but they're still pretty preliminary. But even with the 2D scope, you can get an excellent image. And that's for a number of reasons. There's overlap of tissues, there's shadowing behind tissues. We, of course, know our anatomy and most of all, the parallax error, which is one of the main reasons we advocate for, against using a scope holder, because even small movements of your scope can give you quite a good definition of depth. In terms of one-handed, well, we're all very used to operating in the nose sequentially, and this is really just an extension of that. But you can use two hands with the aid of an assistant. And again, we advocate against the use of scope holders. In terms of its benefits, just very briefly, they are can be categorized into three areas. We have an increased visualization of the middle ear. It's a much less invasive technique from a patient point of view, and there are some functional outcome advantages to our ability to see and understand the middle ear in a closer way. Fundamentally, what we're doing is taking the optics from outside the patient, which is the case in the microscope, to taking it within the ear itself with the endoscope. And with the additional option of angled scopes, we get a really phenomenal view. Illustrated here, we can see that with the microscope through a speculum, really the round window is the posterior aspect of what you can see. Whereas with the endoscope, you can see here the round window, but in addition, you're getting a wonderful view of the sinus timpani, fonticulus, subiculum, the entire oval window. And really, these are structures that are incredibly important with what we do in cholesteatoma, with the sinus timpani being one of the major areas for recurrence. In terms of minimally invasive, what we're trying to avoid is the sort of cosmetically unpleasant side effects, if you like, of some of the other approaches. And also, if we have disease that is only based in the attic, then it seems a great shame to remove a whole lot of tissue in order to get there when there's a perfectly reasonable access through the transcanal route. And as the late David Pothier so succinctly put it, there is little point in doing a facial recess approach when you can access the disease directly through the canal. Functional outcome, well, that's something that has really been reborn by our visualization of pathways such as the isthmus and tensor fold. And the more we understand these pathways, the more likely we are to preserve structures that can ventilate tissue postoperatively and therefore improve our recurrence rates. But this talk is really about complications. I tried to think about how I could organize that. It's a big subject. And I've come up with three maxims that I think we can sort of categorize what I'm going to say. First is from Hippocrates, the oath that we all took from 2,000 years ago, which is do no harm. Second one is a sort of military term that we should never leave anyone behind. And the third one comes from Baden-Powell, who set up the Boy Scouts, who said we should always leave this world a little better than we find it. So how does that play into cholesteatoma surgery? Well, in terms of doing no harm, I'm going to try and give you some real practical tips in terms of how to preserve structures and avoid mistakes. In terms of leaving no one behind, that really refers to leaving residual cholesteatoma. That's the big one. If we can improve our residual cholesteatoma rates. That's going to really help with our recidivism rates as well. And finally, leaving the world a little better than you found it. Well, if you don't reconstruct your ear well at the end of the case, then it's all for nothing. If you do a wonderful resection, but then your reconstruction is poor, it's all going to fail in the post-operative period, and you're going to be back to square one. So let's start with doing no harm. I want to talk about a few really important points. First of all, when you're using an endoscope in the ear, you must reduce the light source. It is fundamentally different from operating in the nose. The end of the endoscope is very hot and it can cause damage. There's been some wonderful studies from the Harvard group that have looked at this, and you can see that just reducing the intensity of the light source by 50% decreases the temperature at that tip quite substantially. And even pulling the scope out, again, moving away from this idea of holding the scope in a scope holder, but pulling it out of the ear dramatically decreases the temperature, therefore the thermal damage that can be caused. Of course, a microscope can still fry a chorda tympani, but it's very easy to do that with an endoscope, especially if you have the intensity too high. Second paper I want to draw your attention to is that of Aaron Iyer from the UK. He did a wonderful paper where he looked at different intensities of light on the same patient and photographed images and then sent them blind to a number of established endoscopic ear surgeons. And you literally cannot tell the difference. So there is no difference in the quality of the image with a 10% light source or 100%. And the reason is that the camera modifies what you see on the screen. So in other words, even if you put 100% light intensity in, the camera will turn down the intensity to your screen. And if you put a 10% light source, it turns it up. So the camera is modifying it. So you always see the same image on the screen. And you can see that actually when you do it in the operating room. It changes briefly and then the camera adjusts. But the difference is you're burning the patient if you send 100% light intensity into the patient. So the temperature difference is huge, but the image quality, no different. Second thing you need to be aware of is Antifog is incredibly dangerous to the inner ear. It is more dangerous than gentamicin. A number of studies have shown that on animal models. So again, fundamental difference between nose surgery and ear surgery is it matters if the alcohol goes in the ear. It doesn't matter if it goes in your nose. So make sure you have that prep away from where you're operating. Of course, it is crucial you keep your eye on the screen. It is very easy to look up and accept an instrument and take your eye off the screen. And if you do that, you very much risk that tip of that scope when you come back in being inside the middle ear, attacking either your stapes or your chorda or your round window. So keep your eye on the screen at all times. That is crucial. If you're not looking at the screen, take your scope out. So I want to move quickly on to leave no one behind. So this is thinking about residual cholesteatoma. I thought I'd begin by sharing with you some of my outcomes. I've been doing endoscopic surgery for about 7 or 8 years now since coming back from fellowship. And in terms of what we've found, our overall residual rate and recurrence rate is pretty low, somewhere closer to the canal wall down sort of figures that you see, rather than the canal wall up. But I really hate this. I hate reducing an operation to one number. It really doesn't do it justice. It doesn't look at any of the other potential benefits, the benefits in terms of recovery, in terms of post-operative pain, in terms of patient experience. None of that is outlined in this single number. So I really hate reducing cholesteatoma to recidivism rates, but everyone wants to know it. So there's the numbers. That's with a mean of 2-year follow-up. In terms of my patient cohort, I can achieve a totally endoscopic resection in roughly 60 to 70% of the time. About 2/3 of the time, I'm using the endoscope and the microscope in a combined fashion, and I really am spending very little time doing modified radicals in this at the moment. Over time, I have increased the proportion that I can get out endoscopically without needing the microscope, but it's plateauing at about 60 to 70%. And that's basically because some disease presents late, it's beyond the reach of the endoscope, you have to use the microscope in addition. And that will, of course, depend on your population, on your referral base. So in terms of how you achieve those sort of figures, well, preparation is everything. You have to look at preoperative imaging. You have to look at the middle ear status. Increasingly, we're looking at eustachian tube function, adenoids in children, anything that can optimize your outcomes. And patient setup is also a very important factor. Patient factors, we're all well aware of, they make a big difference, and optimizing all of those is crucial. Eustachian tube, well, increasingly we have some very sophisticated means of hopefully optimizing our eustachian tubes, and we're starting to use these much more in cholesteatoma surgery. In terms of preoperative imaging, one of the big mistakes people can make is looking at a CT scan and thinking they must do a mastoidectomy, when in reality, the disease may only fill the middle ear. And it's impossible to tell on the CT alone how much of this calcification is cholesteatoma and how much is sequestered fluid. So we, as much as possible, try and use fusion imaging with non-EPI diffusion weighted scans. And that you can see here shows you that the disease is often contained within the middle ear and therefore accessible by a totally endoscopic approach. Even if the CT scan makes it look like you're going to have to do a mastoid, that's not always the case. So in terms of patient setup, again, preparation is key. You must shave the hair, especially if you're, well, maybe not if you're dealing with this chap because he's the world record holder. He'd probably be upset if you shaved his hair. But on the average patient, you need to shave their hair. It's a bit like going through those doorways that have the plastic sheets hanging down. Every time your scope hits a hair, it blurs it and it impacts on your image quality. The other thing that's revolutionized our access has been these hook retractors. They're on a bungee cord and they have a little hook on them. They come in various shapes and sizes. We used to advocate using the Tarabichi stitch with a suture and the Sydney sling. But to be honest, these have gone out of fashion here because those bungee cords are so much more maneuverable, especially when you're taking grafts and so on. In terms of infiltration, it is critical that you get for good hemostasis. But I find that 1 in 100,000 adrenaline is more than adequate to my needs. The other big tip I'd give you is don't over-infiltrate. You might think I need to get as much infiltration in as possible so that it's really blood-free. But what ends up happening is you get a bleb in the ear canal, you get bruising and separation of some of the layers of the skin, and that really inhibits your view. So just give enough infiltration to blanch the tissue, and that's it. You'll find that your dissection is much clearer. We, of course, must optimize our view, stabilizing the endoscope. And a really important point that I stress to my residents is don't hold the instrument and the scope like a knife and fork. You need to think in a Chinese fashion. You need to think like chopsticks because they need to be parallel. It makes a huge difference. If you operate, as many beginners do, like a knife and fork, you will find the instruments cross and you're fighting them in the canal. And that can be quite dangerous because they'll suddenly flip position. You need to get in the habit of entering and operating parallel to your scope. It's super important. So I wanted, hopefully I'm not running too over time, I wanted to go through a quick roadmap for how I address a cholesteatoma and some tips and pearls as we go. It all starts with your incision. The incision is critical. And one of the massive benefits of the endoscope is that you can delineate exactly where you want your incision. We tend to go anterior to the lateral process of the malleus, much more than you would with a microscope where your incision tends to be around here. The benefit of that, the 6 o'clock incision is pretty much similar to the microscopic incision. But the benefit of going anterior to the malleus is that you get this wonderful flap of skin, which you can then peel down, which not only gives you increased access to the attic region for a dissection of cholesteatoma, for example, but also at the end of your case, it is crucial for that reconstruction because it enables you to bring a nice piece of tissue over your cartilage graft to hold it in place. So it always starts with the incision. Once you're in the middle ear, you need to confirm the diagnosis. You need to get a handle on how extensive it is. One of the key things is identifying the incudus-stapedial joint early. It's one of the first things I do. If the IS joint is eroded, you know the incus is coming out and most likely the malleus head. So that's going to make your dissection of the attic region much quicker, much easier if you know they're coming out. If it's intact and you think there's a possibility of preserving the acicular chain, that's going to change the dynamic completely. And you're probably going to want to come in through the mastoid with the microscope so you can additionally address disease around the heads of the ossicles. So finding out what's happening at the IS joint early is absolutely critical. So then our technique is to then remove all disease from the middle ear. We don't go to the mastoid till later. We work methodically. We take away disease using the landmarks and identifying more landmarks as we go. And remember, if you see squame, try and remove it. Don't leave things for later because that's how things get forgotten. So there's a little video here just showing a little ingrowth cholesteatoma from a perforation. Some of the key points here are that I generally enter the middle ear low, below the chorda, and then take the eardrum down to 6 o'clock so that you can reflect it forward later. We then work in the upper part, finding the chorda tympani. That's your next key landmark. The chorda will take you to the malleus handle, and then we switch to a cupped forceps in order to remove tissue in the attic region. That's again quite different to the microscopic technique. The cupped forceps can be used very gently, and under great magnification, you can see exactly what you're doing. What it achieves is an opening into prosac space, and you can see the lateral process. Once you suction, you can see the neck of the malleus and the lateral process. And so that's the sort of next step. And then again, defining that chorda tympani, and then using those spaces that are relatively safe and taking disease off the incudus-stapedial joint, which enables you to decide where you go next. The next big decision is, do you need a mastoidectomy? So one of the sort of landmarks we use for determining whether you need to open the mastoid is how far the disease extends along the lateral semicircular canal. And we used to say the posterior limit, but probably a mid part of the lateral semicircular canal is a realistic cutoff point at which to say, okay, disease is going further than that, I'm going to need to open. We always have a microscope available. We never operate without it. And deciding when you should convert is a difficult decision. Sometimes the disease itself will have eroded the attic, so you'll have a large atticotomy. Sometimes you want to preserve the acicular chain, and you might want to keep a fairly small atticotomy. And sometimes there may be complicating factors like fistulae and tegment dehiscence. So that's going to influence your decision. But fundamentally, you can either have a small atticotomy and convert to a mastoid and operate in a combined approach, or you can go for a larger atticotomy and try and stay purely endoscopic. But of course, there's pros and cons to both. The larger atticotomy, it's going to be harder to reconstruct at the end. It's going to be more time consuming. However, it has those advantages of not opening the mastoid, not disturbing normal tissue. Once you've finished that decision, we move on to the complex aspects of the disease. So you should leave disease around the stapes, around lateral semicircular dehiscence, tegment dehiscence till last. I might skip the video just in the interest of time, but show you this one because this is what moving on from the work of the Japanese group, which used combined approach where you've drilled a mastoid with the microscope, but then you bring your endoscope in underwater to complete the dissection of disease off of the fistula. It's quite a nice technique. I mean, we're not sure if it works well because you've got good ionic comparison between the perilymph and the saline or Ringer's solution. But perhaps it just works well because its hydrodissection is ever so gentle the way it peels off the disease. But we've done maybe 10 or 11 cases now using that technique and preserved the bone in all cases. And one of my colleagues had one this week, and literally the entire semicircular canal was dehiscent, still preserved hearing. So it's a nice little technique where you're combining microscopic and endoscopic techniques. Hearing reconstructions are probably a whole nother lecture in itself. And anatomical reconstruction brings us to our last part, which is leaving the world a little better than you found it. Reconstruction is so important. And unfortunately, when you've been operating for a few hours removing the disease, it's kind of like the last thing you want to spend time on, but it is so important. And I cannot stress how much you should be meticulous in the way you reconstruct your ears. Considerations you need to be aware of are what to do with the head of malleus and body of incus. Generally, I've regretted it when I've left them. I've thought sometimes I can't see disease there. It'll be good to have them there because it'll support my graft in the attic. Invariably, I've found I've left disease around them. So on the whole now, if I don't need them for the hearing and I'm going to do a port, I'll take the malleus head and I'll take the body of incus. Same goes for malleus handle. I think gone are the old rules that you must always leave the tympanic membrane attached to the umbo. We will almost invariably remove it from the malleus handle, and we've had no issues with retained disease in that region or any issues with lateralization. I don't think that's an issue as long as you're not doing an onlay. In terms of size and shape of the attic defect, we try and make it as rounded as possible and as neat with the mesotympanic defect so that your attic repair sits nicely. And I almost always, I would say always, 100% use composite grafts. So we use tragal when we can and conchal when that's not available, but it's cartilage with the perichondrium attached. And I'll show you a video. What we do is, as the defect.
Alex, we are a bit overrun, so.
Oh, okay. Can finish up quickly. Yeah, I think I'm on my pretty much my last slide. Okay, have I got 1 minute?
Yes, sure.
Okay, so you can see here that the perichondrium is larger than the cartilage to fit the defect. I do it with 2 islands, and then you can see the benefit of that is that it slots in and then the attic defect clicks in. So last points are we want a safe, dry and hearing ear. I think we're moving away from this idea of let's cut everything out like Van Gogh, and we're moving more towards preservation and trying to get a functional ear at the end of it all. In the past, that was the case. Canal wall down, chop it all out, microscope approaches, and routine, always do a second look. The present, I think we're moving more towards preservation surgery, endoscopic and combined approach. We're using non-EPI DWI for surveillance rather than guaranteed second look. We're using fusion imaging, and we're managing the eustachian tube. The future, who knows what it holds, but probably looking more towards exoscope and endoscope approaches and some more interesting imaging techniques. So thank you very much for letting me give you some tips and pearls. I hope they proved useful. I'm happy to take any questions.